so proud and happy to bring to you two great friends that have been, we have been working together for a good 6 to 10 years in the beginning of HPCO. This is Brian Tramontini. He is the owner and CEO of Stratim, and he's already on the video with us. And Andrea Binkle, here she is. She is my colleague, executive director. I don't know how to pronounce the name of your hospice. Can you please tell me, Andrea?
Yes, it is Lizard and Innisfree Hospice.
Lizard and Innisfree Hospice. And we are going to talk a little bit about the sustaining quality of hospice palliative care through our information to our data systems. As hospice colleagues, we know that we have to report our stats to the government, but Brian and Andrea will have a very nice and friendly way to share the whys and wherefores of this with us. So a little bit about Brian and Andrea. Brian has founded the Stratim 25 years ago after holding a variety of roles in the government and the private sector. So Stratim specializes in organizational performance metrics with a focus on palliative care. And Andrea Binkle, she is a registered nurse with over 3 decades of experience in healthcare, and she holds a Master's of Arts in Leadership. So I am very proud to introduce you to Brian and Andrea right now, and the floor is all yours. Thank you.
Great. Thank you very much, Monica. I think Brian's going to bring up a slide deck for us.
Yes.
So thank you very much for including us in your conference. And the messages that were happening just before we came on did bring me to tears as well. And again, can't thank all of the staff and volunteers that have been providing care throughout this pandemic, and hopefully it is coming to an end relatively soon. So Brian, if you want me to just go to the next slide. So Brian and I have just probably met almost 2 years ago now, I guess, when I started working with him at Lizard and Innisfree as we were starting our journey in regards to collecting data and looking at how we, again, tell our story about our work that we do. Our presentation this afternoon really is going to be geared to help you as hospice palliative care leaders be able to tell your stories. We know that you live and breathe this every day, and you have some great stories, but you need a bit of data to help to give it some extra oomph when you present it to your partners. So I'll give you some tangible examples of how we're using data and how it's being presented to partners, both at the provincial level and at the local level. And we know that the use of data alone won't tell the story, the whole story. We'll only give you pieces of it, but we also want you to recognize that all of those great stories that you do have, you need to weave in around the patient experience, the family's experience, your staff and your volunteers' perspective as well need to be woven in. And we'll hopefully give you a bit of taste of what that looks like over the next little bit. So back to you, Brian, in regards to starting us off.
Thanks, Andrea. And thank you, Monica, for inviting us to speak. I guess one of the things we want to just set the stage here about why this is such an important element, and especially why it's important right now. And to a certain extent, we're also going to be giving not just the kind of theory behind it, but some very practical examples of how it actually works in action to impact both the organization and the system. Our focus is going to be primarily on system level stuff, but we're also going to be delving into some examples from organizations, and we're going to be using some of the examples from Lizard and Innisfree Hospice. I guess, first of all, one of the big things to set the stage or the context is that we know that, and this is from a study that was done, I think in 2021, and you see at the bottom there the reference to it. And what it says is that Canada is really not performing that well compared to a lot of countries that are kind of comparable to us. So the axis on the left-hand side talks about the percentage of deaths in acute care, and the axis on the bottom talks about the cost. And really, Canada being at the top right means that we are the worst performers out of all these countries. We know that a large majority of healthcare expenditure occurs in the final stages of life, and our system in Canada is one that relies heavily on the acute care system as, you know, just kind of the default option for how this gets handled. The fact that we're performing the worst really sets the stage to say, look, we can do better than this, especially since the impact on the financial impact on the government of Ontario. It's about 35% of our budget. Here's a definition from some work that was done in 2007, and the kind of focus of the paper was improving healthcare quality. And what they're saying is, and you could substitute medicine at the top for, probably any type of healthcare or social service. The quality is doing the right things, the right people, the right place, the right time, really in an efficient and cost-effective manner. This makes a lot of sense. One of the things to note, though, is that while the article is about improving healthcare quality, the definition used is medicine, very much more of a kind of an acute care focus. So, but a lot of these things would apply in any setting. And I'm going to look at another, words have meaning, and the way the words shape the way that we think about things. I'm going to use a broader origin of the word health. And the word health and healing both come from the Anglo-Saxon word health. And it's really talking about restoring a state of overall wholeness, wellness, integrity. And the idea at the bottom that this kind of translates into is a sound mind and spirit and a sound body. That, as a way of thinking about healthcare, is much more holistic, much more real, much more on point than talking about medicine. And this really resonated with me when I thought about the palliative care sector. This is the way the palliative care sector, from my perspective, really deals with the whole person in their entirety. And this might surprise you to have this as a context when we're talking about data, but when you start to accept that these principles are a broader way of thinking of health and healthcare and how we want to treat people, then it really sets the stage to say, well, how do you translate that into actual stuff that works? How do you translate that into data? What are the important things to look at and to measure? And how do we do it? I'm going to pass it back over to Andrea.
Great. So this is looking at data from the provincial viewpoint. And really, I call it the bird's eye view, or BEV for short, and BEV is my daughter's name. So it kind of really resonated with me. But this enables us to fly at 50,000 or 70,000 feet to see what the healthcare system is looking like for patients receiving palliative care. And so this is really giving us a starting point, or maybe even, I wouldn't even call it a benchmark, but just a starting point at this time. So we're seeing that 2/3 of so this was done by Health Quality Ontario, and it was based on 54,000 patients or individuals that had died between the time of April 2014 to March 2015. And it really was showing that individuals we're still going, 2/3, we're still going to the ED or going to the ER in their last months of life. Only half of those individuals actually received palliative care in their last month of life. Less than half actually had palliative home care. And a third actually received a home visit from their doctor. A quarter spent half or more of their last month in hospital. And we know that's not ideal. And Brian will get into preferred location later, where services are better serviced for patients who are at end of life. More than half, again, spent 5 days or longer in hospital during their last days of life. We're going to touch on that a little bit later too, around late referrals and length of stay in a hospice. 62% spent their last days in a hospital, and over half spent an average of 5 to 6 days. And 2/3, 65% of that 54,000 spent their last days or died in hospital. This is what we captured, Ontario captured. Who are those other individuals that also died but didn't receive any palliative care services? Next. We've used the Quadruple Aim to help describe or to start to define our quality improvement measures or indicators. The Quadruple Aim was adopted by our Ministry of Health and is an expectation as the quality framework to be used within Ontario health teams. And the 4 quadrants or 4 indicators are patient and caregiver experience, patient and population health outcomes, value and efficiency, and provider experience. We're going to primarily focus on, again, those external performance indicators that fall into these categories, but we will share a little bit about provider experience as well. The next slide really is just to reinforce the importance of using the Quadruple Aim within the healthcare system. It is being mandated or expected by the Ontario health teams to be using that framework. Let you go to the next slide, Brian. Oops, I'm toddling between 2 screens. So again, trying to align all of some of the performance indicators within these 4 aims. We know as healthcare providers that we keep talking about palliative care being high quality care. We have high rates of satisfaction and positive impact. We know that people feel better about having hospice palliative care services, having effective pain and symptom management. We know we reduce costs, and in the healthcare system, it costs more for a patient to stay in hospital than it does in a hospice or even at home. We do make a positive impact over the general public, population. We talk about different disease cohorts, and we can actually follow them. We know what their journey is going to be like, and we can actually help sooner. We also know that our staff and our volunteers are highly satisfied in the work that we do, and it's positive. Everything's positive. But how do we know that? We have no data. This isn't compared to what. So how can we start to use data within our explanation or within our storytelling about the great work that we do? Again, we know in our hearts this is what we do. but when you're trying to explain it to an external partner, doesn't seem tangible without having a little bit of data behind it.
So now we start to jump into a little bit of the kind of a little bit of harder facts and jumping into how we get into the solution of this. What you're looking at now is what I would describe as a balanced scorecard that is aligned with the Quadruple Aims. So the balanced scorecard allows you to look at various aspects of performance of your organization and really assess how well are we doing in each area. And I will show an actual working example of how this works and what the colors mean and where the data comes from and what you can do with it. But at the highest level, it really looks at a holistic view of the organization. Aligning your performance with the Quadruple Aims, it lets you really ensure that you're going to be, doing what the province is asking for. But it also ties in your internal performance. So it helps you stay on top of, are we being efficient and effective internally? And, how are we working and delivering value to the system? And how do we work in conjunction with the system? So, why is this so important? Well, maybe just a little bit of background. A lot of the data that you're going to see here was developed by a bunch of your colleague organizations. Stratim was engaged by Hospice Palliative Care Ontario, I think in about 2016. And we worked with them to develop a suite of performance measures that would apply to palliative care services. And over a period of a few years, we worked with dozens of organizations and hundreds of people to figure out, how do we describe our own success? How do we judge ourselves? What are metrics that are meaningful to us? This is well before the notion of Ontario health teams came into play. It just seemed like a good thing to do. It made a lot of sense. Part of the drive for this is, as the system started to get looked at more closely for performance and accountability, kind of echoing back the notion that the acute care model tends to be the way that things get looked at. And a lot of the elements of the types of services that the palliative care sector provides don't always line up exactly with that. And if you want to be judged, you want to be judged on your own performance, on things that are meaningful to you, meaningful to the people you serve, and actually describe better to the system what are measures that make sense, as opposed to things that don't make sense. A lot of performance measures in the past have measured activity levels as opposed to outcomes. And we really drove this process in conjunction with a lot of your colleague organizations to focus on what are the real outcomes that are useful and provide benefit and value to the people you serve. At this present time, with the advent of the Ontario health teams, Stratim feels that palliative care service providers are possibly at risk of getting subsumed and having yourselves judged on a more of a medical-based model. So what we've done in conjunction with HPCO is provide a framework to say, here's some good ways of measuring things that make a lot of sense to palliative care service providers that describe more accurately that you're providing value, and these can be used. And a lot of these examples are coming from the Hospice Palliative Care Ontario platform. Some of them have been developed independently by Stratim for our clients, many of which are HPCO members. One of the quadrants or the aims is client and caregiver experience. That's something that you want to make sure that you're delivering value to the clients, that they are having a good experience. So since that time, this is one of the first elements that was developed. There have been approximately 15,000 surveys, and I call them surveys probably not accurately. These are not surveys. These are discussions with the clients throughout the trajectory of their journey, so that the palliative care service providers can say, are we consistently satisfying people? How much of an impact are we having, a positive impact of them? In both cases, the rates of satisfaction and the rates of positive impact are around 95%. You know, is that good? Yeah, it sounds very good. Typically, and the bottom kind of thinks it says CSAT scores, that's customer satisfaction scores. 75 to 85% are generally looked at as good scores. These come from what we call the client check-in process. And what we've done is look at both the clients and the caregivers. So previously, some surveys that were done in the province were done only with the caregiver, and because in many cases, the client had already passed on. So they completely missed the opportunity to talk to the actual person during the trajectory of their care. And that was addressed because those notions were pointed out by the hundreds of people that participated in the development of these processes. This is looking at something that added or changed the way we thought about what used to be called the preferred location of death. When we had these facilitated discussions with people, one thing that consistently came across from the people working in the sector was that people changed their mind about their preferred location of death during the course of their trajectory. And what that meant was, and because there was a broad range of services provided, it's like, well, let's look at it during the course of their trajectory. Let's give ourselves the opportunity to talk to the clients while we can talk to the clients. Let's also ask the caregivers what they think about these things. And again, these aren't surveys. This is based on those 15,000 data points. And there's some very interesting data here. What we're seeing is that when people are receiving palliative care services in a home setting, it ranges from probably about 80 to about 97% of satisfaction. When it's in what we call a home supported setting, it's a little bit lower. It's in the range of 70 to 80%. If it's in a residential hospice residence, it's in the range of 80 to 93%. If they're in a hospital setting, I actually broke this down and didn't aggregate the hospital settings, because if they were in the hospital settings, it would probably be in the range of about 30%. When people were in a hospital palliative care unit, the location preference rate was around 50%. That means only about half of them felt that getting the services there was what they preferred. We see here that the client and the caregiver rates are slightly different. And what this reflects really is that they have different takes on things. The client might always want to be home, but the caregivers sometimes say, maybe it's better if they're in a hospice residence. And looking at these patterns over time, we're getting consistent data, and it will allow us to investigate this a little bit more. One of the most important things to take away from this one is that as the healthcare system changes and begins, structuring itself around Ontario health teams, we believe that the question of, are you getting the services where you want to be getting the services? Is this where you prefer? This should be asked and integrated into all services. This also provides palliative care service providers with the ability to say, look, people really don't prefer not to get the services in hospitals unless they need to. In most cases, they prefer to get the services someplace else. Yeah, as I mentioned earlier, this is not a scientific survey. This is data being collected on a real-time basis and looked at by organizations and aggregated with all of the ones we're collecting data from across the province. But you take a look at the quote at the top from two different studies that said, the use of acute care near end of life is not driven by patient wishes. 87% indicate a preference to receive end of life care at home. So that 87% it's pretty close to the answer that we're getting. We've just broken it down into more detail. It's more granular. We probably have more data points, and we're looking at it from the two different perspectives of the clients and the caregivers. So this is something that is available to you to tap into. A little bit more data, and this is around kind of closer to the patient and population health outcomes aim. And we think what it tells us is that the system really isn't working that well for the people you could serve. That there are people that aren't getting the benefit of your services because they're getting the services too late. The two pie charts you're looking at here, the data comes from primarily from a system called Info Anywhere that a lot of organizations use. There is some data from another system that is commonly used, but it's been integrated for a bunch of hospices. And what it says is that there are referrals that get referred too late. And the late referral rates at the bottom for visiting hospices, around 33%. Right now for hospice residences, it's around 47%. You think about that, and that's saying, close to half sometimes can be late. And so what does late mean in both contexts? Late means the proportion of what we call pre-service deaths plus short service deaths. So pre-service deaths mean people that were referred but passed away before they could even receive the services. That's not good. Short service deaths means that they got the service, but they died in a time frame that was deemed too quick. The parameters around those are different for visiting and hospice residents. They've been determined by, again, the collaborative group of organizations that are working on this. And, they might not be perfect, but right now we have the infrastructure to collect the data and modify those dynamically if someone should decide or have backup about what is the best answer. And I'll delve into how this actually works a little bit more in a kind of dynamic fashion in the example. We feel that these rates are conservative. I was speaking to one organization yesterday that said, we're a small organization. We can't even enter in the data until somebody's going to be admitted. And I know that's the case with a number of organizations. So that means that the pre-service deaths don't get counted at all for those organizations. So again, these are good measures that could be put in place for the system surrounding you and not just within your organization. But at least when you go to the Ontario Health Team, you can say, here's the data that we've got from across the province. Here's what it looks like in my organization. Let's do something about this. This data is not from Hospice Palliative Care Ontario. It's based on some research. We did do a pilot system on some of the data, but I'm not showing that because it was really a long time ago and it's incomplete. This is building on, this is the core of the data that's at the centerpiece of this is the orange bars. And those are really a subset of what the data that Andrea was showing earlier from Health Quality Ontario, where two-thirds of people who received palliative care had unplanned emergency department visits, stayed in hospital 5-6 days, two-thirds died in hospital. So that is the orange bar. And we classified that as general palliative. But in speaking with, with Andrea, I said, we don't have the data on hospice residents, but I plugged in some numbers there as an example, because I think if you're in a hospice residence, you're not having emergency department visits because you're in the hospice, and you're not staying in the hospital because you're in the hospice, and you're not dying in the hospital because you're in the hospice. So the number is probably zero, but I couldn't say it's the little yellow bar with 0.1 beside it on the bar, on the chart to you if I made it 0. So I made it really low. Think of the implications of that being understood. Think of the implications of missing those opportunities and missing those high satisfaction rates and giving people the services where they prefer to get the services. The other data, I just made it up. I plugged in some numbers to say, you know, okay, it's going to be more than for a hospice residents, and it's going to be less than 62%. Because if I'm being given services by a shared care team, or if I'm getting some attention at home by visiting hospice services, I'm going to go to those places yet less. And if it's a general population, that's 62%, the orange bar, that's of the patients who received palliative care in their last month of life. What about all the ones that didn't? The number's even higher. So the potential impact, lost opportunity, is even higher. This is the thing. We need to know this data. It's possible to get it. We have developed mechanisms to get it, but we were unable to really follow through on that because of the transition with the lens. So it's something that we think is an important thing to get, and would look forward to working with Hospice Palliative Care Ontario or other groups that would be interested in you know, getting this data for you. I'll pass it back to Andrea.
This slide is just a reminder of the Quadruple Aims, and using this framework really helps us in aligning or having common language with our partners, as our partners know and understand the Quadruple Aim. And so again, it's just a reminder of that framework, and it can be used for both internal and external communications. For Losard Innisfree, we recently were relatively new to this journey of data collecting and data analyzing and sharing of our story. Losard Innisfree has been and continues to provide great care for its individuals at end of life and supporting families into bereavement. The sad thing is that our partners don't see or recognize Losard Innisfree's impact overall. We're working on that, and we're hopefully getting better as we start looking at this information a lot more. So here's our story. Next slide, Brian. Losard Innisfree is a 16-bed hospice residence. We have 2 sites, one in Cambridge, which is Losard House, and it is 6 beds. And while the other house, Innisfree House, is in Kitchener, and it has 10 beds. We specialize in end-of-life care, making moments matter for our individuals in their last days of life. In our 21 years of operation, we've served over 4,000 individuals and their families. In recent years, we've been expanding our services to include social work, music therapy, spiritual care, and bereavement. We were accredited in 2020 by HPCO. Losard Innisfree is actually members of 2 OHTs, Cambridge North Dumfries and KW4. Losard Innisfree in the Waterloo Wellington area where I'm from, there are actually 4 residential hospices in the catchment area, and 1 acute care site has beds, and another long-term care or complex continuing care company has I think 10 beds as well. So we're well grounded in hospice services in Waterloo Wellington. Losard Innisfree are approximately 40% of our operating budget is funded through home and community care. The rest is covered by donations and special events. So for the last 2.5 years since I was awarded the role of executive director for Losard Innisfree, we've started collecting data, not something they had done before, I started talking a whole new language when I started talking about quality improvement and risk management and dashboards, creating a dashboard with the organization. We immediately aligned it with the Quadruple Aim because I knew that was coming down the pipe from Ontario Health, and I had worked already at Ontario Palliative Care Network with HQO, so was well informed on the direction the province was going in. So what we've done, I've taken information that we've had from the last 3 years and to outline our averages in these 4 quadrants. So in regards to our client care or client experience, we have been collecting the information on our own outside of Info Anywhere, outside of HPCO and Stratim. We had not had access to the check-in tool until 2021. So over the course of the 3 years, we were experiencing our clients, it was caregiver information, I should prefix that, it was caregivers answering the survey, and they were finding that their experience was 95%. They felt there was a positive impact on their loved ones at 97%, and that the preferred location for them really was the hospice, home being the second choice. We had, in 2021, when we started using the check-in tool, and this is again asking questions along the patient's journey, and it's not being interfered with by what the perception of the caregiver or the family members. When we asked our residents that 100% of them were satisfied with the services they were receiving at Lessard and Innisfree, and 96% found that there was a positive impact. I haven't included that on this slide at this point in time because we're brand new at it. We're double checking the data integrity to make sure that it truly is expressing what we're hearing and seeing now. In regards to patient and population outcome, we were seeing that, again, this is over the period of 2021, that we had 250 patients or residents come into our home in that year. But what we found was that 96% of our referrals actually never made it to it. 18% never made it. 96 patients were left either to die at home or die in hospital, and wasn't where they wanted to be. That's quite a shame that we were able to respond. We had 164 patients who were admitted, and their length of stay was less than 5 days. That's what we're indicating as our short stay. We know ideally that we would prefer residents to be there for 3 to 4 weeks, so we actually get to know them and care for them. We've had residents stay as low as an hour. My uncle is one of those examples. After 5 weeks of pushing the physicians to see what the patient needed and what the family wanted, my uncle was actually came to my hospice and passed away an hour later. I was lucky enough to be in the building or get to the building, even though it was during pandemic time, and was able to have family members visit in that last hour. We actually included his daughter, who lived in North Carolina at the time. We actually had her on video conferencing so she could actually see her dad for the very last time, which was quite amazing to do. We should be able to identify individuals sooner that they're able to access the service, or we get to know them and help smooth transition them from their care setting to a hospice. In 2021, almost half of our referrals were late. Breaks my heart that we were not able to meet the needs of of these patients sooner and faster. In 2021, we had 51% of our referrals actually came from acute care and 49 came from community, pretty even split. In regards to value, over 3 years, Losartan Innisfree did not admit one patient back to hospital and to acute care or send one individual back to the emergent department. We were able to help manage the care right within our sites. So it kind of mirrors the Brian's assumptions that he expressed a few minutes ago. But however, we did have 11 individuals, 1% of our population, that actually were discharged. They were discharged either to long-term care, back home, or to retirement home. I know shortly after I started, we had one resident who'd been with us for 6 months. She came into the hospice with a PPS, or Palliative Performance Scale, of 10%. Definitely the family had been called in and ready to for her last days. She perked up, and to the point where she was having a physiotherapist come in once or twice a week, helping her get her strength back and her ability to walk with a walker. She was discharged from our hospice in just before Christmas 2019, and where, when she was leaving, she was so happy that she had the opportunity to experience hospice care, but she said her work wasn't done yet, so that's why she had to leave. But please keep a bed waiting for her because she will be back. I'm happy to say 2 years later, she has not come back and used our bed, so she must be doing extremely well. In regards to provider experience, I've included it here just to demonstrate that we do collect that information as well, and we've been doing that for a good 3 years. And in 2019 or 20 and 21, staff were a little challenged with all the changes going on with the pandemic, and they voiced that through the survey, and that they also were challenged because there'd been a turnover in leadership prior to my starting. So there was some of that trickle effect from 2000 and 2019. Our volunteer experience, again, it dropped due to the pandemic, that people were finding it very difficult they're disconnected from the hospice, and how could we help that? We started bringing volunteers back slowly to the organization, and we could see from those individuals that their experience was higher, but for those who were still not back at the hospice, it I guess changed the average a bit and brought it down into the 80s. So things we have to work on. Next slide, Brian. So this is an example of what I see and my clinical team see in our dashboard, so that we're able to actually monitor this information in a timely manner, instead of just aggregating over a year or over a couple of years of time. So this is where we would be able to discuss with our partners what is happening. And we're using the late referral screen here, and we're able to start talking about the data, the real-time information. Losartan Innisfree has worked with Hospice Palliative Care in Ontario and Info Anywhere. We have the data entered monthly, and it's uploaded into HPCO and then to Stratim on a monthly basis, instead of having it done just on a quarterly basis. We found it wasn't timely enough for us to make changes or to start those conversations with our partners about what could change, how could we make a difference. So again, this gives us a bit of a bird's eye view of how we're operating, how things are going for us, and we can actually move the conversation out beyond our 8 walls. So you can see in 2021, we actually started the year off with quite a high late referral rate, was well over 55%. And with conversations that we've been having with our acute care partners and being able to basically decant the hospitals a little faster or sooner for those individuals that would benefit from being in a hospice or want to be in a hospice, we've been able to drop that rate down to 38% by the fourth quarter. So you can actually see the changes that you're making. That meant we're seeing patients' information sooner, we're able to admit them sooner and faster. And it changed our length of stay data a little bit as well. We were, averaging around, 12 days at the beginning of the year. We've been able to drop it down to 8 days, but they're not dying, within hours of being in the house. So we're able to start seeing that difference. We're able to ask questions with our partners, having a different conversation than just saying we're doing great work, and it's the why. Why is this happening? Why is that happening to our residents? How can we help move people from the community or from the hospital sooner and faster? How can we find that sweet moment of making referrals versus waiting till individuals are in crisis and need to be admitted very, very quickly, and then only have a short length of stay with the organization. So again, it's enabling us not only to tell our story, but ask different questions and how we can improve the care. Lessard and Innisfree, we're evolving on this journey. We're getting better at data collecting and demonstrating it. The use of the tools with HPCO, Info Anywhere, and Stratim have made a world of difference for us to be able to view and draw pictures for people in what we do. We've been optimizing those tools the best we can. We're going to continue expanding the use of these tools. We've used the fund development module and the finance module, and we're now moving into using the strategy and project management tools to help measure our success, our 2022 to 2026 organizational care plan or strategic plan direction that we'll be able then to continue to demonstrate our success as a hospice residents. Lots more to learn and lots more to add to our story. But this is our journey, and we've been pleased to be able to share this information with our partners and for them to help make the journey for patients easier and better. Brian?
Thanks, Andrea. So I'm just going to take a second because we're going to move into the demonstration part. It's going to be a live demonstration with the tool set online. So I just have to get out of PowerPoint and move into the tool set. So this is the actual balance scorecard that is aligned with the Quadruple Aims. And I apologize that I can't do too much for the size. I'm going to try and make it a little bit bigger, but then it affects the functionality. So what you see here are a number of what I would refer to as the Quadruple Aims with some things that we're measuring underneath it. And let's just pretend that those are measures for the moment. If you were looking at about 20 measures times about, let's say, 10 time periods, you'd be looking at 200 pieces of data. And if you were looking at those 200 pieces of data with just numbers, this is what it would look like. And for each number, you'd have to stare at it for a while and say, how can I tell whether this is good or bad? Because I have to really, really think hard about what that number is and what it means. When you have a scorecard, your eye is immediately drawn to the red, and red means bad, green means good, yellow means it's in the middle. The light green means it's not quite hitting the target, and the light red means it's not quite as bad as the intolerable level. And it's really as simple as that. But if you had to look at 200 numbers, it would take you forever. Adding the visualization really helps to make this much more powerful. But when we look at this a little bit more closely, these elements underneath the aims are actually not measures. They're actually what we refer to as outcomes, which are really composite indices of a group of measures. When I expand this into time periods, you'll see that some of the data may be collected on a monthly basis, some of it may be collected on an annual basis, some of it may be pulled out on a quarterly basis. Again, really too many numbers to kind of just look at and stare at. Now we're actually going to drill it into measures, and there's even more. So the measures are the actual performance metrics where the data is collected, and then you can do analysis and tell whether performance is good or bad. A lot of these measures come from, in this case, in this example, come from the Hospice Palliative Care Ontario metrics platform. Most of them don't. Most of them come from other places. The data can come from other systems that you have, or it can come from something that you put in. It can come from a line of business system. It can come from the metrics platform, or you can just enter it if you don't have any other alternative. So there are a whole bunch of different measures. And when we look at, I'm going to roll this up to the row stage again, the outcome stage. There are different elements that deal with external performance. A lot of the top ones, the experience and the outcomes, are more externally focused. A lot of the value and efficiency things are more internally focused. Any organization that's accredited, has to deal with financial stuff. So there's tools built into the platform to integrate your financial data. There's techniques to integrate some of your human resources stuff. Strategy, governance, and risk are things that you have to have good business practices on if you're going to get accredited. The Stratim platform provides the tool set to deal with those types of measures, and those all get integrated into your scorecard for your organization. So this doesn't replace other systems. It's not to duplicate other systems. It doesn't have all the detail in other systems. The purpose of this scorecard is to pull together your overall organizational performance to help you improve internal performance and to understand what's going on in the system. So what is this? What are these colors? Where do they come from? What do they actually look like? Each performance measure, and I'm using this fictitious demo example so that it's clean and simple. Each performance measure has its own characteristics. So this fictitious day program satisfaction rate, what's the purpose of that? Did we achieve our targets? The definition is, the percentage of responses that were very satisfied, let's say. Some people would use that. Now, why are the colors red or green? The red at the top is because the actual performance, which is the blue line, is worse than the baseline. The baseline is where you want the red light to show. That's when it's like, I'm worried now, I got to do something. The colors on the right are all green at the top. That is because the actual performance was better than the target performance. And the colors in the middle, the light red is where the performance is just before the baseline, light green just before the target, and yellow kind of right in the middle. So any performance measure that you look at gets translated into this automatically. And you can kind of zoom around within different aspects of your performance to say, what's going on, how are we doing? And if you happen to, something happens and you want to record comments about this on the scorecard, you actually can make notations about why performance was good or bad at this particular point in time, what you did. And that's automatically built into your overall platform. Measures come from different sources and they all get integrated into your scorecard. This provides you with a view of the different types of measures and what their what we call the relevances. Well, that's what the overall in normal words, if you said this is why this is important, that's there. And depending on which ones you're working on at one stage, it tracks where you're at with the different parts of the your performance suite. The balance model provides an overview visual as you're developing a suite of performance measures and looking at the performance from different categories. So what does it look like? How many do we have in patient and caregiver experience? How many do we have in outcomes, value and efficiency? So that as you're developing your suite of performance measures, you can say, are we missing something? Is there an area that we're kind of heavy on, or is there an area that we're light on? When we did this one, we found that using the Health Quality Ontario's dimensions of care, some work was needed on the equity component, the equity dimension. An important consideration is often, are the measures objective or perception? So a survey is a perception. An objective measure is, the length of stay. How long was guy here for? You don't want to have only perception measures. So only doing a bunch of surveys and not having objective data is really not that good. Only having objective data and not ever getting the perceptions is not that good. You want to strike a balance between these things. And as you're building your suite of performance measures, you're making sure that they are aligned with outcomes. You're not just measuring to measure. And you're making sure that you're covering off all of the bases. I'm going to go to one of the examples that we showed a little bit earlier and drill into a little bit more detail about this. This one. This is the kind of like along the lines of the example that Andrea was talking about. Okay, I guess it's been a while since I logged in. I'm going to drill into this chart that we saw a little bit earlier. Now, this isn't just a chart. I can actually decide that I want to look at one particular time period. In this case, now I am going to look at just 2021. I'm going to go back to that chart. Now I have different data. And I want to see who are these people that had pre-service deaths. So I can actually drill through to the raw data and see that that number 132, I can identify each individual, not with names and addresses. It's just an identifier in the system. So you can go back to your system where the data came from and see who it is if you need to. All we want to be able to see here is these are unique individuals and what was the nature of their data? Why were they in that group if you want to do something about it? So if I want to see the number of pre-service closures, again, there's supposed to be 37 of them there. I can drill through, there's the 37 people for that year. So it's not just about pretty pictures, it's actually a highly auditable system that can let you dig right in and make sure that all the data makes sense. We also can use this for data quality issues. So for example, there were instances with some organizations that their processes didn't include recording the date of death consistently. We're actually able to calculate the rate that was missing so that then they could go in and fix it because they could also see who it was missing for. If we look, this is actually an example of some of the reports that are within the work that Lizard and Innisfree Hospice is doing. So as Andrea was talking about, they're implementing their strategic plan. So we've got some components in here that will describe, and they're just starting out here, so they don't have all their progress stuff in there. But they've got 37 projects in their strategic plan. When they start tracking them, they're going to be able to get results and say, how well are we doing in the execution of our strategic plan? Which initiatives are we doing? What stage are they at? What does it look like? And again, these will tie into their overall scorecard.
Brian, there's just a question here that is probably well to put it in here. Question is the baseline the same for all hospices across Ontario? Because a lot of this information for the hospice residents has been driven by HPCO or through HPCO. So is I guess the baseline the same for all?
Yes and no. If you have only the HPCO metrics platform, then they set the standard across the board. If you have your own copy of the tool, then you can get your data with your own baseline and target performance if you want. So for example, if you want to set your own baseline and target for Lizard and Innisfree Hospice within the Stratim tool set, you have your own instance of it and you can set your own baselines and targets. If you don't want to get your own instance of it, then you simply use the HPCO tool and you get their provincial standard for that measure. So in some ways, because the nature of the way the measures were developed as rates as opposed to raw data, the normal ones that are set centrally by HPCO work well. But for example, if you're talking about your financial data, that's not part of HPCO. If you're talking about, let's look at some in this next example. I'm going to look at some clinical data. So in this, it's just taking a little while to fire up, I guess. Here we go. So let's say we're looking at some clinical data. This is your own data. You set your own baselines and targets. So you need your own instance of the tool for this. So let's say we were looking at hand hygiene compliance. This is using Public Health of Canada's technique for doing compliance audits. And this would be your data. You would set your baselines and targets, and this would break it down by the different kinds of people who would be doing the audits. So if I want to see what the compliance rate would be like for nurses versus this group versus that group, the tool allows you to do that. If I wanted to look at an example of financial data, this would allow you to look at your own financial data. These things are not at all in any way touched by Hospice Palliative Care Ontario. You have your own copy of the software. It's your data. It's private to you. If you are part of Hospice Palliative Care Ontario, you can get your data from them integrated into this. Likewise, the data that we pull from Info Anywhere, it's your data for you. You can share if you want to with Hospice Palliative Care Ontario. So it's not one size fits all. There's many different systems that the data can come from and get integrated into this platform. So this is an example of what you might see in your financial system data. So you want to look at different categories of accounts and how are you doing relative to your budget targets. So at any point in time, you can see the different categories, and the ones in red say, well, we're not hitting our target. We're over or under. If it's a budget, we're over or under if it's an expenditure. So all of these things come together to provide kind of a holistic view of your scorecard. And that's really the key thing that is tied into the Quadruple Aims. So the notion here is that we have a balanced scorecard. It's tied into the Quadruple Aims. It pulls together all the other types of information that your organization is responsible for internally and externally. You can set the baselines and the targets with your own version of this. And so it's really a way of you being able to get a handle on your own internal organizational performance. But if you have partners or collaboratives or groups where you want to come together and build components together and share the information to be able to compare one against the other, you can do that as well. So that kind of, I would say, concludes the demonstration part. So I'm going to flip it back into the presentation now.
You want to bring up the video?
Yes, thank you.
So again, part of telling the story is hearing the voice, either of the patient or caregiver. This is one of our videos that we were working with Rogers TV, and they came in and did some professional recordings for us. And this is a patient's husband and his story. Brian, do you have the sound on it?
I'm going to try, I'm going to pause it, and I'm going to try and set the sound louder if I can.
No, you haven't optimized the sound on. I don't know if Scott can chime in. Turn off the video, it's fine. Brian, it's not optimizing sound. Sorry about that, but we can link it with this slide deck later, and it can be distributed as well. Yeah, it's checking at the bottom. There's two boxes before you that you have to check before you put on the video. Don't worry about it, Brian. We're just watching the time.
Okay.
But we'll send it out, and people can watch it, or the YouTube link. So sorry about that. But again, the importance of having family and patient story woven through the use of your data really speaks volumes to the partners.
Okay, sorry we weren't able to get the sound on that video to come across properly. It's sorry about that. So I guess just kind of before we get into questions, just kind of to wrap up, telling the theme was telling your story with data. Really go back and think about the story you want to tell. Think about the changes in the system you want to create. Work towards building your capacity to tell the story with data. And there are a lot of tools available. If you're an HPCO member, that helps. You don't have to be an HPCO member. A lot of the tools can be available to you directly, and you could use your own organizational performance and your own measures. You can create all these and do it your own way. In terms of the message about why this is important, we know that the system is kind of heavily defaulted to acute care, and with the health teams, it's really important to be able to tell your story and the impact that you have on the system. You want to tell your story. You want to influence positive change. Encourage your health team to align their performance with the Quadruple Aims and make a lot of the things we talked about today part of that. Consider making the location preference rate something that would be used by your health team for all services. Ensure or also advocate for getting system impact data, like the performance around the acute care deaths and days in hospital, and measuring ER visits and stuff like that, and really changing your organization and working towards influencing the system around you. And now I guess we will open up for some questions. And I don't know if I have to go through the Q&A thing or if somebody's doing that on our behalf.
No, I can do
I
that
have-
for you.
Okay.
There are quite a few questions and comments as well, so we just selected a few. So the first one's from Elizabeth. She asks, have you replaced Grand River Hospital on King Street, Kitchener Hospice? Are you another new entity?
So the Grand River Hospital has their Freeport site, which has 10 end-of-life care beds or palliative care beds, but we have not replaced them at this point in time. In Lessard and Innisfree, we've been around for, like I said, 21 years. Kitchener-Waterloo just recently opened up another 10-bed residence through Hospice Waterloo, and that's in the north part of Waterloo is where it's located.
Okay, thank you. Next question is from Jacqueline Richards. She says, most often we have to work within the parameters of a PPS of 30% or less before completing a hospice referral. This is problematic and causes delayed admission or no admission. Who has set the parameters or guidelines regarding when to submit referral for hospice?
So in Waterloo, Wellington, it's the same. It's usually 30% is when we would want to start to admit individuals with PPS of less than 30. But if an individual is, not a hard and fast rule that if somebody has a PPS of 40 and you know they're declining quickly, a referral can be sent in. Because the sooner we know about the individual, the sooner we can start having conversations with the resident or patient and the family and lining up the timing for a bed offer. So it's not a hard and fast rule that it has to be 30%, but it's usually 30% for admission, usually, but it's not a hard and fast rule.
Okay, thank you. And Deidre Thomas is asking, is the baseline the same across all hospices across Ontario?
I think Brian answered that question because I asked him when he was doing the demo.
Okay.
Yeah, the answer is no. You set your own if you have the product for yourself.
Okay, and the last question we have here is, measures come from HPCO. What other systems or spreadsheets do you use? Did you develop the scorecard based on geography, demographics?
Yes, we actually have incorporated demographics into some of the models. If you have the demographics, we can pull in data from scorecards. We can pull in data from other systems, provided you can export the data or provide us links into the system. And we can tie in with a number of systems. We showed a lot of data from HPCO. You don't have to be part of HPCO. You don't have to contribute to the HPCO system to use this tool set. That's just an example we showed because a lot of people, palliative care service providers, are members of HPCO, and we want to show the value that they provide. But you don't have to be a member, and you can use this for whatever data you want. And it doesn't have to be palliative care data. We have clients that are in other parts of the healthcare system.
Okay, and actually one last question just came in. Can I ask how the individual hospices agreed to a common data measurement tool? I assume this was coordinated by HPCO.
Yeah, HPCO took the lead on developing the metrics platform because there was really a void. And it was, they felt it was important to be able to tell their story, to tell the story of the sector in a way that wasn't just bound by the medical model and measures in the acute care system, a measure that would reflect the value and the values of your organizations in a way that really made sense for you and made sense for the people you serve. So HPCO took the lead on this. It took a few years. There were hundreds of people involved, and I think about 70 organizations took part in the consultative processes.
Okay, thank you.
Allison, there's a couple more above, just one from Natalie.
Okay.
From Wayne.
The pre-service death one?
Even go up by one a little higher.
Oh, here we go. We need to stop considering a short stay a failure. For many people, they only don't want the act of death to occur in the home. They want to be home as long as possible. A short stay can be a success. So I guess that's more of a comment.
So I would say we probably classify it as red. Absolutely, a short stay may not be a failure, may be exactly what the patient and the family wanted. But if we don't identify those individuals, like what I have, it was 65 people or 96 people. Not all 96 of those individuals wanted to be in the hospital just less than 5 days. So it may be, again, as part of the conversation, is there a cohort of patients that don't fit that criteria for short stay? Because
The other part of the answer, oh, sorry, Andrea.
Go ahead.
I was going to say the other part that directly addresses that is that, you know, it's not like we set the baseline at, you know, 0% that doesn't allow any of them. There's going to be a certain amount. You know, it's kind of like the example of zero unemployment is generally considered to be around 4 to 5%. Every piece of unemployment doesn't mean it's a failure. So the baseline and target parameters address that there are going to be some that was the intent, and it's not considered a failure, but it is a fact. Here's how long it was. It was a pre-service death or it was a short service death, and that's it. There's going to be a certain amount of them, and that gets built into the performance parameters as part of the work. And those can be adjusted.
Okay. I think the rest are just general comments. Just do one last look here. And then who has set the parameters or guidelines regarding when to submit referral for hospice? But you've already answered that. So I think those are all the questions, unless anybody has any more.
I have one request. Could you please elaborate a little bit more to our audience the importance of early referrals and why 30% PPS not always helps us to have these early referrals?
I'll take a stab. So when I worked as senior director at the CCAC years ago, my staff told me that at 30% is the tipping point for resident and the family. So if we could identify people at 40%, 40 or 50%, and I worked really hard and having my team do that, it actually helps the conversation prior to that tipping point of 30%. That if we could actually have referrals made sooner, we could have the conversations and help with a smoother transition. I think the healthcare system itself set up that parameter of 30 PPS admission to hospices as 30% because they felt that is the end of life stage in the hospice palliative care journey, right? So they're still in transition. They could get a little better, but normally they're gonna decline. But once they hit the 30%, you know they're on a decline. So I think that is the 30% was sort of a system decision based on the hospice palliative care journey.
Okay, thank you. And there's actually a question in the chat. Can someone explain one of your first slides showing Canada as the lowest in what?
That is part of the study that was done. Well, you can see the source there online. And this was the big, it's CD Howe report commentary number 608. Somebody Googles that, there's a lot more information than just this slide. So that's really where it came from. So what it basically means is Canada is the worst amongst those countries. The most people that have an acute care death in a hospital and the highest cost in the last, I think it's 3 months, 180 days, 4 months, 6 months.
Okay, thank you. I think that's all our questions. So I'll hand it over to Monica. You're on mute, Monica.
Sorry. Okay, thank you so much, Brian and Andrea. That has been awesome. I hope that this presentation has been an eye-opener to our fellow colleagues, executive directors and CEOs of hospices around the province. It's so important to have the right measure, real measures that reflect real life in our daily life in the hospice. And I can only thank you for all the good work for the last, I think, 10 years, right? At least 6 that I remember. So thank you very much. Would you like to share any final words before we close the conference?
Andrea?
No, thank you very much for including us, and we're happy to answer any questions. Our contact information is available there as well in the slide deck. And Brian, you'll be sending that and forwarding that to Monica after we're finished. So thank you very much, everyone, for having us.
Thank you very much for the opportunity, Monica. Thank you very much for the opportunity. And if anybody has any questions, or if anybody wants to get their own demonstration for their own organization, there's no charge for that. We'll be more than happy to be able to get into details with anybody that they'd like to get into.
Thank you very much. So we come to the end of our day. I hope that all of you, our attendees, have enjoyed the self-care day of rest and learning a lot and broadening your horizons. So now, as you leave the webinar, please click leave the webinar on the little red button on your bottom right, and you will be taken to an evaluation call, so that we can learn from you. What else would you like us to give you during our annual winter conference? Thank you so very much for your attention, and you have a wonderful weekend. And we see one another again in 2023 on the first Friday of February for our next winter conference. Thank you very much. The day is adjourned.